down, almost completely stops, and then there's a thin string that connects it eventually to the trunk of the internal jugular vein. Sometimes we have far more complicated situations where the sigmoid sinus comes and it stops. This may be another form of congenital venous problem. The internal jugular vein is formed here in the vertebral plexus, eventually does form, but has another stenosis here, another stenosis here, and is not actually a very well-functioning internal jugular. If you were to go up here and try to catheterize this, you would never get to the sigmoid sinus. It's not connected to it. Sometimes you can get very string-like stenosis here. Other times you can get, again, something similar to what Zamboni showed. Sometimes we see that the vertebral vein will come in towards this area, or the deep cervical vein will come in, and again, probably a congenital abnormality. In this particular case, it's the only case I've seen so far in about 1,000 cases where there actually, in fact, are still beautifully large draining veins. The deep cervicals and vertebrals completely take over. This person has no jugulars at all. Here's another case where the person has two jugular stumps, but there's no jugulars again associated with this. But this individual actually has a beautiful vertebral plexus development, and almost like out of an anatomy textbook, you can see beautifully here the intervertebral veins connecting this. And so these people all survive because they can develop collaterals. If you didn't have those collaterals, you wouldn't survive. However, maybe some people aren't so lucky that they do get collaterals, but they can't develop a vertebral plexus. So there's so many variables here for us to understand who gets better and why they get better. We need to be able to map out all of these type of flow and anatomical variables that are present in the system. And to do that, we need to do not only multiple sclerosis patients, we need to do normals as well. Here's a patient where the internal jugular vein comes down, narrows, and merges into the external jugular. So again, lots of different variations that exist here. If we're lucky, this may show. There we go. So one of the things that we can also do with MR is create these lovely three-dimensional rotating images. You know, if it was in Avatar, we could give you these nice goggles and you could really look at it in 3 dimensions coming out at you. I think that's blue like the Avatar, but it's blue for veins. And you can see again that the whole vertebral system, you can see the pinching here of the internal jugular, and you can see here the internal jugular just coming to a stop. So I like these because I would love, you know, Don and Mike and all the others who use this to actually have that available to you prior to your treatment so that you can visualize what it is you're dealing with these individual patients. Now, in a visit with Paolo just before the meeting in Bologna, he was kind enough to show me some new data he had collected using the intracranial Doppler. And he told me that some of the most important areas are the ophthalmic veins, which can show reflux, literally oscillations that go positive, negative over time. So no bulk flow, basically. And also the petrosal sinuses here. So these are pretty small vessels, as you'll see in a minute. We haven't been imaging the flow in these. That's the next challenge, David. I'd like us to start doing that instead of the superior sagittal sinus and the transverse sinus, because Paolo claims that these are the ones that show the dramatic reflux, dramatic oscillations. So to see if we could do that, we went back into the data and took one of the 3D data sets, and sure enough, we can see easily the cavernous sinus, we can see the pterygoid plexus, we can see the inferior petrosal sinuses. And if we look at this again, if we project over a large amount of the neck, it's hard to differentiate these. So we narrow this down over a small region and look at it, and now we can see very clearly the left ophthalmic vein, which means you can put a cross-section through here and measure the blood flow, and you can see the superior and inferior petrosal sinuses almost directly out of that textbook image I showed you a minute ago. So if the data is good enough, we should be able to go and locate these and do that type of measurement. So what can MR do to help assess CCSVI? We can look at post-contrast time-resolved MRA to study the vasculature. We can do flow quantification. We can use SWI to study both the iron and the small veins in the brain. And for more information, you can go to these websites, nice-mri.com and ms-mri.com. The MS NICE project is something where we're trying to get people to send us data they've been collecting. And I think what we need to do is collect a database with thousands and thousands of cases. So I know David has worked hard to get other sites involved with this who can contribute data. I'd also like to see sites who at least could send us de-identified data can do this. And a European group has just sent us 800 cases. And I'm hoping that if we can start collecting that type of data from everywhere in the world, we can have thousands and thousands of cases. The only thing is I'm going to need hundreds and hundreds of graduate students to do the processing. So we're definitely going to need people to help process, and then this database is going to help us understand what's happening. So what about blood flow? Why is this important? Well, if you had a group of radiologists here, they would look at this image, they'd say, okay, these look just fine. I don't see any problems here. I can see all the vessels. You know, what's the big deal? And in fact, you have to remember that I believe Zavadanov's work only used the magnitude images. He did not use flow quantification. Now, I can happily tell you that Robert just sent several of his people to spend time with us a few weeks ago and learn how to do flow quantification, so they will be adding this to their future studies. But here's an example of what we get. If we do a cross-section through the neck like this, we can see all of the vessels in the neck very clearly. In terms of direction, positive flow towards the head is shown in bright white here, and the negative flow towards the heart is shown as dark. We can get the cross-sectional areas for every vessel, and that means that by measuring this image, this is what we call a phase image, which is directly related to the blood flow, we can calculate the total cardiovascular input into the brain and the venous output from the brain. And Mike showed a few examples of this. Here's a case of normals where we're looking at the major veins. They flow at about 10 centimeters per second. They don't really have these wild swings associated with them, as he showed. And here's a case where the person not only has reflux or zero flow in one vein, all four of the major veins in this individual have come to almost zero or reflux flow. And so because of that, in order to get that blood out, talk about a stress on your system, the flow has to double in the second half of the cardiac cycle, and it becomes 20 centimeters per second in order to get it out. I've actually seen flow as high as 60 centimeters per second in an MS case because of this type of problem. So this is a movie now actually showing the flow through the different vessels. Here's the arteries. Sorry, I'm at, oh darn. Let me see if we can do this one more time. And I want you to notice right here, there's a thin band in the left internal jugular that may represent stuck valves, that the flow is basically jetting down through that part. There it is, you can watch, see it go, and then it goes right through here. And it actually is, it's almost zero flow for much of the time, and only later does it jet through that. Now here's an example we just did with a group in Las Vegas that only started about 10 days ago. And this is the first case they did. If you look at the normal MR images, again, the vessels look fine. But if you do the, in this case, 2D flow quantification, you can, and this is actually 2D time of flight here prior to flow quantification, you get this terrible banding effect. The reason for that banding is the flow in this jugular is going forward, backwards, forward, backwards. And so it creates this banding artifact. You'll notice there's no banding artifact on the other jugular, which is flowing just fine. So that's kind of a visual representation that there's a problem. One can then go and measure the flow here now. You can see that there's only one vein in this person's neck that actually is functioning properly and carrying most of the blood. Most of the other veins have almost no flow in them at all. So does having only one major vessel compromise an individual? Perhaps so. I think Mike indicated that there was a paper done a number of years ago in craniectomies, I believe, that people were studying what happens if you hold the neck like this for many hours during that surgery. And what they found was that people who had 3 times or more flow in one jugular compared to the other were the most prone to getting some stroke or some cognitive effects after that. So this individual would not be a good candidate for that particular surgery. Now this is a case from Canada where a patient came in and had a narrowing here in the lower area, was then treated, rescanned, and now looks pretty good. Got sick again. I think we had a question on that.